Upon Dr. Madhu for his talk on surgical management of infectious keratitis.
Very good afternoon to all of you. In the next few minutes, I think I'll cover therapeutic keratoplasty. Now that you have seen all the speakers speak about the medical management, this is the last frontier in the management of infective keratitis. When nothing works, then you have to do a TPK. So I also come from a place that looks like Kerala, the Godavari districts, and in this district itself, you have a lot of fungus that is marking around in these fields, and our agricultural laborers do often come with a lot of fungal ulcers. So the scope of this talk would be under the following headings, and I was fortunate to be trained under Dr. M.S. Sir, who is the longest practicing corneal surgeon in India till date, and I think fungal keratitis, as all the previous speakers told, is more common and severe. And these are the cases that require transplant more when compared to other microorganisms, because at least 20 to 40% of fungal keratitis will end up with a TPK, and outcomes are poorer, especially in cases where you have a larger ulcers, and the cost of treatment also, when you take into account, the fungal keratitis costs nearly 3 times more, and paradoxically it affects the poorer people more when compared to the richer people. So in our practice, we see around 3 to 4 new ulcers every day, and we operate on a TPK alternate day or daily nowadays. So before going into TPK, I would suggest that you try some methods like the intrastromal injections, and if you have very small perforations, glue with BCL or Tenon's patch graft, because TPK is really the last thing you want to do on a patient, being a very challenging surgery. So this is the intrastromal injection. This is the preservative-free ozole that is available from Oralab. So if you see here, with a 30 gauge needle, you go to the edges of the ulcer, in 360 degrees, you try to hydrate it like your side port wounds and see that beautiful hydration that is seen. So usually it takes around 2 to 3 injections in deep ulcers. Most of them heal well, negating the need for a TPK. And sometimes if it doesn't heal with the second or third, that is when you have to decide to go in for a therapeutic graft. So that demonstrates the intrastromal voriconazole. Next is the glue with BCL. So if you have a perforation like this, perforation actually from the microbiological standpoint of view is the best thing that can happen to an ulcer, because it renders the ulcer sterile. So in this situation, you can plan for a good quality tissue and plan for a optical grade tissue and plan for a PK instead of a therapeutic grade tissue, but make sure that the margins are well covered. Before that, you can salvage the eye by using a Tenon's patch graft or a glue with BCL. Now coming to the therapeutic keratoplasty, the main aim of this is to eliminate infection and not visual rehabilitation. So don't bother about how much tissue you are taking or how much aggressively you are going here. But remember that whenever you are going to do an TPK that is more than 9 millimeters, the results are definitely going to be unpredictable, and it's mostly going to be an eye-saving procedure rather than a visually rehabilitative procedure. But in our practice, it's sad that we usually give our therapeutic grafts to our PGs or even fellows. That should not be the case, because if you see in future, I think TPK would be the only surgery that corneal surgeons would be doing. Because rho kinase inhibitors and endothelial cells, DSEC is gone, with cross-linking and scleral contact lenses, DALK is gone, Cyan-Bos is disappearing, the scars that are there. So I think if you want to be a corneal surgeon, you have to be good in your TPKs. That's the only surgery you will be doing. So now when do you do it? That's the question. So what we usually follow is, once you identify the organism by the beautiful things shown by the previous speakers, you know the organism, you have given the correct treatment, you wait only for 2 weeks. At least it should stabilize, or you should see some signs of resolution. It doesn't definitely implicate in case of acanthamoeba required, but usually in fungal cases, if you are in the right track, you see some signs of resolution within 2 weeks. In our case, what we do is topical natamycin, voriconazole, itraconazole. Systemically also we give some antifungal along with doxy for its anti-MMP activities, regular debridement, and we try 2 intrastromal voricanazoles. If it doesn't work, that is then we take a call for TPK. So this is the procedure of TPK. So preoperatively, it's very important that you get a good hypotony and you also get a good block. Especially you need a good facial block so that the patient doesn't squeeze. And whenever you're giving a preoperative mannitol, make sure that the patient also goes to the toilet before he comes into the OT. That's a very practical thing. Otherwise, you'll end up with a bedpan on the OT. And this is the thing that once you do the cutting, make sure that you peel off all these things that are there in the iris. This is the most challenging thing, because this will cause lots of bleeding. And next important thing is create PIs, especially if the eye is phakic, and also make sure that they form the angle well by sweeping the edges. So these are the things that you have to follow. And also when you're doing the trephination, look for the actual extent. Sometimes the endoexudates and hypopyon will give you a false scope of the extent. So go with the paracentesis, clear off the AC, and then look for the ulcer proper, and then try to oversize the trephination by 1 to 1.5 millimeters, right? Next, what are the intraoperative complications that you can have? One is the bleeding from the iris that can obscure your visibility. Next is the lens expulsion. Then you have the dreaded complication of an expulsive or suprachoroidal hemorrhage, being an open sky technique. So this is the video of lens expulsion. Lens expulsions usually follow cases of perforations where the entire lens iris diaphragm comes and attaches to the endothelium. In those cases, if you don't release the adhesions and directly go ahead with surgery, this is what can happen. Still, whenever something like this happens, try to create a capsular opening and try to retain the PC at least, because once you are retaining the PC, you're still maintaining the separation of anterior chamber and the posterior chamber and not allowing the infection to go behind the PC. So that is one important thing. And maybe the vitreous surgeons will not agree, but despite of mannitol and other things, if I find the whole globe is still very hard, I don't hesitate in doing a vitreous stab and making the globe soft. It gives me at least 20 to 30 minutes of hypotony to finish off my first 8 to 12 sutures. That is one practical point you can implement. Next, even in cases like total corneal ulcers, do not lose hope. Sometimes these patients also can recover well. So this is the case where you can see that the ulcer is totally from limbus to limbus, but still in these cases you just have to do a freehand dissection and put in the entire bulk of the tissue, and those you can see the endoexudates. Here you can use the hydrocannula to gently help you while you're lifting these exudates, and they peel off well from the iris. And these definitely would require a glaucoma drainage device or trabeculectomy eventually, all these large grafts. The post-operative care, because most of them are fungal, you cannot start on steroids. You can still use cyclosporin and tacrolimus in these cases. IOP control is very important in these cases, and try to use drugs that have BAK because those have antifungal properties. So in take home is, whenever you have given maximum medical therapy, try to act early. Don't let the fungus expand till the limbus and do a perforation. When things are under control, you try to do it. Pre-op hypotony is important. Grafts about 9 meters will definitely have a poorer prognosis. Try to regain the angle by the 1 mm endothelial skid that Mark Terry has described. Post-op infection and IOP control is important. Thank you. Thank you for your time and space.